I just want to introduce myself briefly. I am Katie Jett, like Ruby said. I am a professor here at Goldfarb School of Nursing at Barnes-Jewish College in the St. Louis area. And like she said, I do practice part-time as a family nurse practitioner in a pediatric urgent care for kids here in the St. Louis area. And I'm really excited to talk to you about asthma phenotypes. I teach pathophysiology and have done so for about 5 years here at the college. And the thing about pathophysiology is that it's rarely changing. We have a pretty good understanding about most diseases. However, what we've learned about asthma has really changed in the last 10 years, and particularly when we get into the phenotyping and endotyping of different types of asthma characteristics. So I'm super pumped to talk to you about asthma phenotypes, and I hope that you leave here today with a better understanding of what they are and how they can potentially impact the care that we give to our asthmatic patients. So with no further ado, we're gonna get started. So today our objectives are to look at the concepts of what an asthma phenotype is and some of the benefits of asthma phenotyping and endotyping with characteristics of asthma. We're going to look at some different proposed phenotypes and describe their characteristics, and then examine the role of biomarkers in the pathogenesis of asthma. So all of you, I'm assuming, have some vested interest in the care of our patients with asthma. Maybe you teach about asthma, maybe you're nurses, respiratory therapists, physicians. What you know about asthma has probably changed over the last several years. When we look at asthma, we really do have this complex clinical disease or syndrome, which is a grouping of characteristics related to the disorder. What do we know for sure? Well, there's airway inflammation, which has now been being focused on as the dominant characteristic of asthma, intermittent airflow obstruction, and bronchial hyperresponsiveness. Again, in the recent years, what we've learned is that asthma is not always a reversible airway disease. There are irreversible changes to the airway, and the role of inflammation has really shown to be a prominent player in those remodeling and irreversible airway changes. And so when we think about that, the understanding of these different the different characteristics and phenotypes kind of substantiates that different phenotypes could potentially influence the way that we treat our patients and their responsiveness to particular treatments. So I just wanted to refresh your memory of what a phenotype, endotype, genotype is. So when we talk about phenotyping, we're talking about what we see. So those are observable characteristics that result from the interaction of the genotype with the environmental characteristics or environmental factors. The genotype is the genetic makeup of an individual. That's what determines the specific observable characteristic phenotype of that individual. What also we know about asthma is that it's a heterogeneous disease. And patients with asthma have a variety of different clinical symptoms. I always teach my students in both Patho and my Adult Health 1 course that of all diseases that you are going to take care of in the acute care setting, asthma is probably the most unpredictable. 2 patients walk in, they both complain of shortness of breath and an asthma exacerbation. And you know with working with asthmatics that the plan of their care or the outcome of that patient is totally different from the one that they came in with. We know that asthma is not a single disease. It's a clinical syndrome with distinct phenotypes, distinct characteristics. The goal here and what the implication for asthma management is if we can really define those phenotypes, identify patients according to those characteristics or symptoms, maybe we can have specific individualized target treatments that best benefit those patients. That could mean that we could really minimize those long-term consequences of chronic inflammation, like airway remodeling, and decrease the amount of exacerbations, particularly those life-threatening that require emergent management, and hopefully increase the quality of life that our asthmatic patients have and minimize the amount of daily symptoms that they exhibit. Phenotyping is not new. Phenotyping is not a new concept. However, in the last 10 to 20 years, we've become more specific on the different types of asthma phenotypes that come into play. It's no longer just allergic versus non-allergic. More recent studies and analysis are trying to kind of cluster those patients by looking at a multitude of possible features. Some of these things include the age of onset of the asthmatic, whether they have an atopic predisposition, the severity of their airway obstruction, and requirements for medications as well. Some examples of those phenotypes include early onset mild allergic asthma, could be later onset asthma that's associated with obesity, severe asthma that does not have an atopic factor with it, and frequent exacerbations. So we can kind of further refine those, and when you refine those, you get specific pathophysiological mechanisms. And when you look at pathophysiologic mechanisms, biomarkers, and those kind of things, we are actually grouped them in a different term that's called endotypes, and we're going to talk a little bit about that on the next slide. Endotypes are even further kind of specific groups, and one of the examples listed there is in aspirin exacerbated respiratory disease, and we're going to look at some other proposed phenotypes and endotypes too. When you think about why this understanding of distinct groups is beneficial, well, when you kind of identify not only characteristics that we see, but relevant cellular and molecular biomarkers, there's promise of really predicting an individual's asthmatic response to treatment. And so we'll be able to kind of get into a more individualized approach to not only the diagnosis of these patients, but also the management and treatment, and hopefully, again, looking at those better outcomes for our patients. I love this slide here. This slide talks about asthma, again, not as a disease, but a syndrome. Again, very variable symptoms, recurring symptoms, and then those three pathophysiological findings that are really distinct with asthma, which is airflow obstruction, bronchial hyperresponsiveness, and inflammation. And so when you dissect those characteristics into phenotypes, we're looking at not only how they present, but triggers and also treatment response. When you further kind of break those phenotypes apart, you get subtypes that are called endotypes. And this is really a growing area of recognition of these distinct types. Endotype is the underlying, kind of describes the underlying molecular, functional, or pathological mechanisms of disease. One of the big goals of understanding endotypes is identifying proposed biomarkers, and we're going to talk about those a little bit later. Those biomarkers will allow us, hopefully, the prediction of the response to that individualized treatment that we're hoping to get for our patients with asthma. Okay, as far as asthma phenotyping, and we've kind of touched upon this, I just want to understand, I just want you to understand that we're looking at different asthma groups. And in conjunction with those pathophysiological or genesis type changes, both at the cellular and biomarker level, how we can treat them could be very, very specific. And hopefully in the near future, we'll be able to really titrate that diagnosis and management individually and target those patients to maximize their benefit of treatment and increase their quality of life and outcomes as asthmatic patients. Establishing a phenotype in an individual with asthma is incredibly important. It's most important in patients with really moderate to severe disease, because those are our patients that are going to have the poor outcomes. And sometimes these are our patients that are not responsive to normal treatment measures, especially if they're not well controlled with the usual course of therapy. As many of you know, we kind of look at asthma in the past and even still currently as this kind of stepwise approach. You know, do they have intermittent symptoms? Do they have more daily symptoms? Do they have symptoms every single day? Do they wake up at night with cough and shortness of breath? Do they have some medications? Do they have multiple medications? And so we kind of have this blanketed stepwise approach. With asthma phenotyping, that doesn't necessarily apply. We're able to really specifically target treatments to the patients that are going to have the maximum benefit of those treatments. So why is it important? Why is asthma phenotyping so important? If you can identify that phenotype, the clinician, the primary care doctor, the nurse practitioner in the urgent care like myself, if you can understand the pathophysiology, you might be able to determine a better, more unique, appropriate treatment to control that asthma. So I want to give you a couple of examples of why this could be potentially life-changing for asthmatic patients. Think about, let's say, allergic asthma benefits from allergen immunotherapy. However, non-allergic asthma does not. Therefore, you can target that particular treatment. Individuals with allergic asthma could be instructed on how to avoid those allergen triggers, how to change some of their life habits, increase the medications during seasons of the year. When they might have an exacerbation, that could also you could also pre-medicate to avoid those flares. Patients with asthma exacerbation respiratory disease or aspirin sensitivity-related disease, you could really train or treatment could be aimed at aspirin desensitization. It could help with those nasal polyps. If someone has an infectious asthma phenotype, they could be treated early at the onset of that respiratory infection to prevent an acute exacerbation that lands them into our emergency departments across the country. Sometimes in kids, particularly with children with this phenotype, they might be able to discontinue treatment between infections, both in adults and in children. That could be possible. So you can see how identifying those specific phenotypes could really titrate more specific therapy to our patients. Okay, so we're going to look at some of the asthma phenotype biomarkers. These biomarkers that we're going to look at, particularly probably one of the most important biomarkers is eosinophilia. I'm sure that most of you remember the pathophysiology, the importance of eosinophils in asthma. They are markedly elevated in blood counts with severe forms of late onset asthma. We also know that the Th2 cells, the T helper cells, are thought to be largely responsible for stimulating that eosinophilic infiltration into the airways. And also the principal cytokines involved in the influx of those eosinophils, particularly when we look at interleukins. And one of the three of the interleukins that we know are really predominant players are interleukin-4, interleukin-5, and interleukin-13. So when you think about what that means, well, first of all, interleukin-4 and interleukin-13 will both upregulate adhesion models and lead to vascular cell adhesion. And that's going to facilitate the entry of those eosinophils into tissue sites of inflammation. So why is this important? Well, if you're able to identify that a person with asthma has a larger than a normal amount of sputum eosinophilia, if you identify it, that's usually evidence of a Th2 or a T helper 2 cell type of inflammation in the lungs. Let's talk a little bit about Th2 cytokines, those T helper 2 cells. These cytokines are important roles in the pathophysiology of allergic disease, particularly obviously for this topic, asthma. And the reason that you see what happens is normally adults and children have a lot of Th1 cells, and these are anti-inflammatory cytokines. Well, one of the proposed mechanisms that an individual will have more Th2 cytokines is that they're not exposed to normal pathogens, normal infection or exposure to endotoxins like in dirt or around other children. And that will disrupt the balance between Th1 cells, cytokines, which are anti-inflammatory, and allows for more production or overproduction of these Th2 cells, cytokines, which are actually pro-inflammatory. And so you'll see they're more likely to have chronic inflammation. What I'm talking about, and this has been validated in multiple studies, is the hygiene hypothesis. That hypothesis I'm sure you're familiar with. But what it means is that these kids, these younger infants and children that aren't exposed to normal infection, they lack that exposure or endotoxins, again, like in dirt and other things, that they're more likely to have more Th2 cells. Well, what do we know then? What if we could inhibit the Th2 cells? Or what if we could promote stimulation of Th1 cells? Could that suppress the Th2 cytokine cells and alter the allergic inflammation? Maybe. And that's kind of powerful as well. lastly, if you look at that exhaled nitric oxide, what we know is that nitric oxide is produced by all tissues in the body, including the lung. Also, exhaled nitric oxide has been shown to correlate with moderately with bronchial and blood eosinophilia in patients with asthma. So it gets produced and is under the direct control of Th2 cytokines, the cytokine that more specifically is interleukin-13. So when you see elevated concentrations of exhaled nitric oxide, you're seeing it's reflecting an increase in that interleukin-13 activity, which would indicate that the patient has a Th2 phenotype. Exhaled nitric oxide particularly has been shown to predict the likelihood of steroid responsiveness more consistently than some of the things that we do in practice, like spirometry, or doing a bronchodilator response test, or peak flow variation. So that's kind of interesting as well. Okay, this cell looks at both goblet hyperplasia, but when you look at the center of the slide, you're seeing the Th2 cells. Th2 effector cells have a very central role in orchestrating the allergen-induced inflammatory response. And you can look at some of those different interleukins that we've talked about, interleukin-4, interleukin-13. Those stimulate the B cells to synthesize immunoglobulin E, while interleukin-5 is necessary for eosinophilia inflammation. The Th2 cytokines are involved in mast cell proliferation too. And remember, those mast cells are those bags of granules that contain histamine and some of the other inflammatory mediators. So they promote inflammation in asthma, particularly of the bronchial mucosa. Okay, so the next upcoming slides, this is not information by any means that I've constructed, but when I did a significant literature search, I found this information to be pretty powerful. So the following slides are going to illustrate the summary of the task force for reporting phenotype study populations. This asthma phenotype task force was a collaboration between the National Heart, Lung, and Blood Institute, the National Institute of Allergy and Infectious Disease, the American Academy of Allergy, Asthma, and Immunology, and the American Thoracic Society, as well as the European Respiratory Society. And the goal was to kind of develop definitions of different asthma phenotypes. And that's what they were really charged with. They looked at definitions of the asthma phenotypes, and then they also kind of developed this characteristics of the population, basing this upon demographics, the clinical features, comorbidities, physiology, and asthma biomarkers. And as a result, they came up with some distinct phenotypes. Now, these are just proposed phenotypes. This is by no means something that everybody sees as phenotypic, but it was really powerful at looking at some of the different categories and the different phenotypes that arose. So we're going to look at this really quickly. Okay, so this asthma phenotype task force defined 9 different phenotypes. Remember, these are characteristics of asthma syndrome. And they looked at 3 different categories. So the first category was trigger-induced asthma. And we're going to go through each of these individually, so I'm not going to spend too much time talking about them here. The second category was clinical presentation of asthma, how someone presented. And then the third category were inflammatory markers of asthma, eosinophilic asthma, and then also neutrophilic asthma. We talked a little bit about eosinophilic earlier, and we're going to look at it again some more. All right, so when we look at the allergic phenotype, this is probably the most common phenotype, and it can account for up to 88% of asthmatic patients in the current literature, and they looked at multiple different studies to try to cluster out these key phenotypic presentations. This tends to be a higher prevalence in children, but still can significantly prevalent in the older adult. Characteristic clinical findings associated with this: younger patients, an onset of an earlier age, more so than that of non-allergic, male predisposition, a positive family history of allergies, and with a seasonal variation, and then exercise-induced symptoms that were more frequent and severe than in the non-allergic phenotype. Okay, The non-allergic phenotype. This is an asthma in patients that do not demonstrate allergic sensitization. With the allergic type of asthma, and I'm going to go back here, this allergic phenotype, how they determined that they were allergic, they did sensitization. So at least one positive prick puncture or in vitro test specifically looking for immunoglobulin E. And they also did antigen and allergen testing. And so we saw that they usually had seasonal symptoms, symptoms related to exposure, or with the seasonal sensitization and exposure type aspects. The non-allergic phenotype did not. They had very normal or low IgE, and they did not demonstrate any type of allergic sensitization to allergens. Characteristics for this phenotype particularly were a later adult onset, and that makes sense when we think about the earlier onset of allergic. Female predisposition, personal or family history of allergy, very few seasonal triggers. It tended to be more severe than allergic asthma and less responsive to steroids. And therein you find how you can get very specific with treatment. And it often coexists with asthma-sensitive asthmatics. That accounted for up to about 10 to 33% when they looked at the literature. The next one that we're going to talk about is asthma-exacerbated asthma disease. So, or excuse me, that should say aspirin-exacerbated asthma disease. That's a typo there at the top. So this is someone, it's associated with an asthma sensitivity, asthma triad or the Samter's triad. And if you remember that, that's nasal polyps, asthma, and aspirin intolerance. This was associated with more severe refractory asthma, which was a major risk factor for severe asthma in outpatients. In the aspirin-sensitive asthmatic, this isn't just a little reaction. This aspirin sensitivity can be very severe life-threatening asthma attacks. And again, it's often associated with nasal polyps. One of the first presentations or first symptoms of this clinical feature was rhinorrhea and nasal congestion. They often have a recurrent rhinosinusitis, and they're commonly poorly responsive to pharmacological treatment, which was one of the findings that the Asthma Task Force identified. Typically, when they have this asthma sensitivity, they're going to manifest these symptoms within 1 to 3 hours of ingestion of aspirin or some other type of COX-1 inhibitor. And I really already talked about the other things that we talked about. This is, again, associated with more severe status type, non-responsive to normal measures of asthma exacerbation. Okay, infection-induced asthma, or actually we'll go back here. Asthma-exacerbated respiratory disease. This is one that's, again, more severe. Aspirin can trigger life-threatening things. We talked about rhinorrhea. And then also with the infection-induced asthma, which makes it a little bit different than the asthma-exacerbated respiratory disease, is that you'll see respiratory tract infection may be the contributor or affect the severity of the exacerbation. Typical respiratory tract infections will contribute this as either associated with a new onset of asthma, associated with the exacerbation of an asthma, coexisting with other comorbidities, or sinusitis, and that can affect the long-term control or day-to-day symptom management. And then it's also associated with a more persistent or severe type asthma. There's many common infections, and the way that these infections are categorized by is either a new onset infection and an exacerbation infection, and or some kind of precursor. So when we kind of looked at these, I divided them. So when you look at this, is it a new, is it persistent, or is it an exacerbatory agent? So RSV we see a lot with new onset asthma, particularly with kids. Rhinovirus is an exacerbated one, influenza is an exacerbated infection, and so forth and so on. At the cellular level, you can see the neutrophils will infiltrate and may cause a defect in the epithelial cells of the asthmatic's airway, and that's going to allow for viral replication and proliferation. Exercise-induced is another phenotype. And when you think about exercise-induced asthma, it really refers to airway narrowing and decrease in expiratory airflow. The task force kind of defined that the term exercise-induced asthma is actually inaccurate. It's really exercise-induced asthma attack, not asthma. And exercise induces that bronchoconstriction. Characteristic clinical findings of this is that asthma exacerbations are a result of exercise. Typically within 5 minutes of aerobic exercise, within 5 minutes after exercise stops, you're going to see this occur. Bronchoconstriction is going to peak around the 10 to 15 minute mark. Typically, you're going to see a greater than or equal to 10% decrease in that forced expiratory volume in 1 second after exercise. These patients have symptoms that are better controlled by short-acting beta agonists, like short-acting albuterol, whereas they're less responsive to steroids. Pre-asthma wheezing in infants. This phenotype is really interesting. So this is somebody that a child who wheezes early in life. I see this a lot in my clinical practice. I work in an urban area. We see a high amount of asthma, and we oftentimes will see these early wheezers. How this kind of looks at the predictive ability of this early wheeze. So they divide it into 2 subtypes here, the phenotype. Episodic, which is a viral wheeze occurring with symptoms of a viral cold. These kids will not wheeze between incidences. And then there's the multiple trigger wheeze. This is notable for wheezing present during and in between acute viral episodes. Regardless of the wheeze, both of them are associated with airway inflammation, remodeling, and decreased lung function, notable by age 3. You can see some changes are present by age 15 months, maybe as early as age 1 year. Lung functions will definitely show differences at age 15 months to 3 years. And then with this particular type of asthma, we have and I'm not going to get into too much detail, but there's the pre-asthma wheezing in infants and children where they have a clinical index or predictive, the asthma predictive index that looks at some variables for determining whether or not they have a high % of developing asthma by age 6. The major criteria for this are eczema or parental asthma, or newer clinical guidelines show for a positive aeroallergen skin test, doctor diagnosed with the two disorders. And then the 2 minor criteria that you can see are a positive food skin test, wheezing without a upper respiratory infection, or the presence of eosinophilia. Basically, if they have a positive index, you have a 65% chance of asthma by age 6. If they have a negative predictive index, they have a 95% chance of no asthma by age 6. And that's, again, one of the determinants. And this is obviously if you have a positive index, whether 1 major or 2 minor criteria, these are the kids that you want to watch because they really do have a greater chance of going on to develop asthma. And that's really important with history and screening for these guys. Okay. Exacerbation-prone asthma. This is we looked at several different studies that Asthma Task Force did, and in one 2-year study, they identified about 123,000 patients. Exacerbation-prone asthma is kind of one of those endotype subsites. When you look at this, it accounts for about 500,000 hospitalizations annually, a significant portion of asthma healthcare dollars. Well, that makes sense. These are the people that are coming into the emergency department and are admitted, and that admission cost, the treatment costs are very, very high in these patients. About 4,000 patients are more likely, when you think about exacerbations within the first year, so this is a new onset asthma with an exacerbation type phenotype, they're 9 times more likely than the other subsets to have a second exacerbation. And that's huge. If they have an exacerbation within the first year, they're highly likely to have secondary exacerbations. In a couple of different other studies, incidentally, we found that you can even subset this phenotype into, yes, they're exacerbation prone, but whether it's not a true prone to exacerbation versus a coincidental non-predisposed form of exacerbation. So this you'll also see as far as risk. They get the forced expiratory volume in 1 second, less than 69%, so significantly lower. Risk factors include African American ethnicity, having a history of pneumonia, early age of onset, NSAID exacerbated airway disease, or worsening symptoms with menses. They also will note more commonly they're being prescribed systemic steroids, or they're upping the doses or increasing the use in their inhaled corticosteroids. Okay, another phenotype is asthma associated with an apparent irreversible airway limitation. This is probably one of the ones we know the least about. But what the Asthma Task Force proposed is that there's evidence of both airway obstruction and a reduced forced expiratory volume in patients that are treated with both anti-inflammatory agents like glucocorticosteroids or bronchodilators. They typically have a less than 90% of predicted in a patient taking those after even the acute administration of a rapid onset bronchodilator. So their FEV1, FBC ratio is below the lower limit of normal for that age. Okay, and again, I just want to point out, of all the ones we're going to talk about, the Asthma Task Force said this is probably the one we know least about, this subgroup. And it's really concerning as far as what type of incidence, associations, and biomarkers. So I'd see this area as one that they're going to see probably more literature and research in the next 5 to 10 years. Okay, eosinophilic phenotype. So these are under the category of inflammatory markers of asthma. This group has an eosinophilic-induced inflammation. We could likely say that this is a Th2 type of phenotype because of the properties of eosinophilia. They tend to have poor asthma control. They have increased bronchodilator response, which is an interesting concept. Exacerbations in the inhaled corticosteroid patients, often a nasal triad association, a normal body weight, and if you were to check the biomarker, diagnostically you see greater than or equal to 2% eosinophilia in the sputum. Okay, the neutrophilic is the other type of the inflammatory markers. The neutrophilic is not as much information about that as the eosinophilic asthma patient phenotype, which we have a lot of information about, and I spent some time talking about the Th2 role and the interleukin roles with that earlier. This might increase with worsening asthma or increase inhaled corticosteroid use. And it can also be seen in conjunction with the eosinophilic asthma phenotype. These patients tend to have be older asthmatics with pretty severe disease and might be seen with less lung function than the other asthma phenotypes. So we've gone over several different proposed phenotypes, and I will tell you there are many others. And we're going to look at a slide on the next slide that shows obesity and some other factors, early onset versus late onset. Future directions and kind of looking at this is really a summary of what we talked about earlier. There are medications that could potentially inhibit those biomarkers we spoke about earlier, particularly the different interleukins that promote inflammation and promote chemostaxis, promote mast cell degranulation. And by inhibiting those, you could decrease the number of exacerbations and also the chronic inflammation that we associate now and know is the real predominant factor with asthma. This was many analyses clustering these characteristics from many studies that show there are many potential different types of asthma phenotypes. This is not set in stone. This is something that is continuing to be evolved. I work at Goldfarb, like I said to you before. We are no more than 2 buildings away from the Genome Institute at WashU. This genomics and genotyping, phenotyping has significantly changed the way that we look at disease. And when you think about asthma, I think it's incredibly powerful. And again, when you look at phenotypes and endotypes, we're really merging those characteristics that people will present with, those clinical findings, with those pathophysiological findings to further weed through this information to generate even more specificity with endotyping. This slide is really interesting. It kind of looks at the asthma phenotypes via that cluster analysis and plots them according to their relative expression of symptoms and inflammation. And I apologize, you can't see the line on the bottom. So on the left, it says symptoms, and on the bottom, it says eosinophilic inflammation. And this looks at concordant versus discordant symptoms and disease. So when you look at this and kind of how to relate to it, the disease is concordant if you look at the middle. And the concordination here is when symptoms and inflammation increase in parallel. However, in some patients, we don't see this. Some patients have discordant disease. And that's an example of that if you look at the line on the bottom, inflammation predominant. So these patients have a lot of inflammation, requiring very high doses of inhaled corticosteroids, but they have fewer symptoms, which means that they require less bronchodilation. Again, titrated, specific. Monitoring the inflammation will help to lower the exacerbation frequency, not the day-to-day symptom management. And so it's not in the role here, and you can take a second to look. You've got early symptom predominant versus late symptom predominant versus obese non-eosinophilic. Noting here you have a large number of symptoms on the left, but not a lot of inflammation. I think it's so powerful. The takeaway here, it really, my whole goal in talking to you is, yes, if we identify these phenotypes, it's not a one and done. It's not a one size fits all. And that's the takeaway here, is that we're going to be able to potentially very individually target our patients. I take care of kids, and they come in with a variety of symptoms. And there's not a mold to fit every single one of them. So if we can determine that this treatment is going to better promote good outcomes for our patient, that's so powerful. I don't want to see these kids constantly in the urgent care with exacerbation. If we can manage them on an outpatient setting, really targeting their syndrome and their disease, they might have a better quality of life, they might have better outcomes, and I think that that's incredibly powerful. So, looking at what treatment can we use with patients? What's the role of the phenotype? And I think we kind of hit those big pieces here today. Okay, guys, that's all I have for you as far as content. I have several resources that are listed here for you, and this is some of the ones that I use, particularly if you note the Lockheed on bottom. That's the defining phenotypes, and it looks at the different types of phenotypes, and some of them that we listed. Obviously, there are many, many, many more evolving literature topics on asthma phenotyping and endotyping, and so this is an area that interests you. Feel free to reach out to me, and I can try to get you more references. But I think it's incredibly exciting, and I hope that you enjoyed learning about it. I will take any questions that you might have now. Yes. Okay, Kathleen, thank you for that question. Yes, this is not a futuristic thing. This is currently ongoing. So there are medications that have been developed that can block certain things, particularly some of those interleukins, and that is a hot source of pharmacological development right now. So I would say that this is ongoing, not futuristic, but as far as FDA approval and indications, we're very, very close. But what you can do, and this is what's interesting, Kathleen, is if you take this phenotype and you know that they require greater amounts of corticosteroid use, or that they're not responsive to corticosteroid, you are tailoring that already just by looking at the medications that we commonly use for asthma. So the tailoring and individuality is not futuristic. We can start to apply this just by good history taking and potentially doing some of those biomarkers on our patients. So we can actively be doing this now, particularly with asthma specialists and asthma institutes where they see predominantly asthmatic patients and are kind of leaders in asthma research. But no, it's not futuristic. We can actively start to look at the meds we normally give in that stepwise approach and eliminate or increase ones based on the type of asthma that patients have.
It looks like there aren't any more questions, so we will wrap it up here, and we're actually on time. Thank you so much, Katie, and I apologize for the audio trouble we had, but this webinar will be edited and then put on the American Lung Association of the Upper Midwest YouTube page, and I'll also be sending out a copy of the recording to everyone who registered today. So thank you.
All right, thank you guys.